Welcome to a conversation with the experts on hypertension. I'm Ambrosia, interventional cardiologist. I've been practicing in the East Valley for nearly 27 years, and I've had an interest in secondary hypertension and treatment for hypertension for a long time, and I'm glad to be here to have this conversation.
Thanks, Al, for having me. My name is Dr. Santosh Desai. I'm one of the interventional cardiologists here at CVM. Been practicing here since 2019. Also, a huge part of my practice is preventative cardiology, and this is a big hot topic.
Yeah, my name is Tandon. I'm 1 year out of fellowship. Hypertension is a very important topic in terms of prevention, and excited to have a discussion about this and talk about novel therapies that we have.
Myself and Dr. Tandon do not have any disclosures. Dr. Desai does some work for Philips, which has no relevance related to hypertension or treatment of hypertension. So our objectives for the lecture today is to discuss the management of hypertension, really starting from the initial diagnosis to treatment from a cardiovascular perspective, and ultimately to discuss renal denervation therapy, which is an exciting new invasive treatment for hypertension. Just initially, I want to start by talking about hypertension, and it seems like an old topic because it's like we talk about every patient about high blood pressure, so sometimes we get a little kind of lulled into a little complacency. But hypertension is still a major problem in the United States. I mean, now 50% of adults have hypertension, and studies really show 80% of those patients do not have it under control. And it's really the number one preventable cause of heart disease and stroke. And so, it's, again, I think we get a little bit complacent. We, check blood pressures on patients and they're like, 135 over 85 or 142. And, patients have been on meds forever. And I think sometimes I know myself, I sometimes lose track of, just how important the treatment is. But clearly the studies show that reducing systolic blood pressure 10 millimeters of mercury has a huge impact on major cardiovascular disease and all-cause mortality. Since it's so common and like there's all kinds of other cardiac disease we're dealing with, heart failure, all the other things, how do you try to put it in perspective when you're talking with patients?
Patients often ask me the question, well, why? Why am I dealing with heart failure with preserved ejection fraction, or HFpEF as we call it, or diastolic dysfunction? And they may not have another identifiable cause, whether it be coronary artery disease, or in some cases, they're not overweight, they may not have diabetes, but they have high blood pressure, or they have some evidence of what we call end organ damage, whether it be heart failure with preserved ejection fraction, or maybe some early chronic kidney disease, or maybe something as simple as just shortness of breath with minimal exertion. And for them, when we try to identify risk factors, that's where I really focus in on things like high blood pressure, cholesterol, diabetes. But the high blood pressure is a big piece of it, I would say. And so when patients ask me, well, why is this happening to me? Why do I feel this way? Oftentimes I'm referring to their blood pressure, which may be poorly controlled.
On top of all that, I also think that there's points where we'll have patients who they start asking, what's the point? Why should I be treating this? And so it's that preventative aspect, but there's also, the aspect that patients will say that I don't have any symptoms. And that's, the important thing to educate patients is that the number one symptom of having high blood pressure is no symptom. And so I think that's an important distinction that we need to make and continue to educate patients on, to try and prevent these issues that come up, heart failure, preserved ejection fraction, kidney disease. There's a lot of data that supports that controlling blood pressure decreases your risk of having cognitive decline, dementia, things like that. So education, I think, is very important.
Because we have the unique perspective of not only, trying to prevent disease in the office, but then we have end-stage disease that we treat in the hospital, and we see the secondary effects of poorly controlled hypertension, whether it be MIs or strokes or kidney failure. We have that unique perspective where we're seeing disease states at multiple areas of the spectrum. And so for us, we're more sensitive to it because we know if you don't treat this now, the downstream effects are going to be costly.
Is that really looking at it as a spectrum, and it's really not difficult to, convince the patient who just had an MI or was in with heart failure to take his meds because they feel that, and we know that they benefit, and that's that asymptomatic person that, if we can really impact it and not get them along the spectrum. So that's a great point.
It's hard to have a patient visualize themselves decades down the line, because unfortunately that's, you're not going to see the effects of high blood pressure immediately, unless you've had a hypertensive emergency or whatnot. But usually people already know at that point that they've had hypertension. So to make them look down the line to be like, hey, we're trying to prevent something from happening decades, that's kind of been the issue, I think, going forward.
Yeah. And it is kind of interesting. I mean, we talk to patients about that with other therapies. We talk to them about statins. We talk to them about that. And we're really talking about that 10 to 20 year down the road. So I think that's a great way to look at it.
Yeah.
So we do get patients that get referred for hypertension treatment. Oftentimes it's the asymptomatic patient who's seen the primary care doctor. Their blood pressure has been elevated a couple times, but they're pretty reluctant to take meds. So, what's your initial approach to the evaluations, and, what are the questions that you ask the patients that help you make a decision on, what's your next step?
Patients may not necessarily want to be given a diagnosis, and certainly, patients, especially nowadays, may be resistant to starting medications. So I guess a lot of the questions I want to know is, well, is this a new thing for you, or is this more of a chronic issue? And, oftentimes the blood pressure may be elevated in the office, and we'll allude to that later in the presentation, but this whole concept of white coat syndrome, I want to know what the blood pressure is at home too. And I want to know what else is going on in your life. Did you come into the office today and have 3 cups of coffee, or have you been drinking a lot of energy drinks because you got a big project at work? So I want to know what else is going on in your life that may be what I call reversible factors first, because I'll always address that before we talk about maybe initiating antihypertensive treatment strategy. So for me, when we talk about the initial approach to a patient, I want to know, data points is helpful for me. So not just one pinpoint data point in the office, but over the course of maybe several weeks, what is happening both in the office and at home, and then what other reversible factors may be propagating this elevation in blood pressure.
On top of that, some of these other things like stressors in their life, like has something happened at home? Also trying to figure out what their diet incorporates. Like, are they eating out a lot? Are they having high salt intake overall? They say that the average American diet has 6 to 8 grams of salt in it per day. So are they really at that level? Are they trying to be strict with sodium or restrictions? So things like that I think are important questions. And then in terms of the initial evaluation, I think some of the stuff that I personally try to start off with is at least when they get referred to us is at least start off by checking an EKG. See, is there any evidence of hypertension already causing some sort of hypertensive cardiovascular disease or anything like that?
So for the primary doctors that do EKGs in their office, what are you looking for on the EKG?
Yeah, so I'm looking for evidence of left ventricular hypertrophy, things like that. Do I see any, atrial enlargement, sequela of having long-standing hypertension? That's really what I'm trying to look for. Is this truly a new diagnosis that's more recent, or have they been in hypertension for a long period of time, but they've just never been diagnosed? Because again, there's no, the number one symptom of hypertension is no symptoms.
And that's a great point. I think that sometimes we look at the EKG and we do them so routinely, but seeing left atrial enlargement, seeing voltage for LVH, seeing, some ST abnormalities that are, usually they're non-specific, but that there may be some underlying hypertensive disease developing.
Yeah.
On checking the blood pressure, what do you guys do as far as when do you tell them to check it? Are there instructions you give them on, first thing in the morning? Should they be resting for a period of time? What do you tell them?
By the time they usually get to us, most of these patients may already be on a medication, and this may not be a brand new diagnosis. So for me, I generally find it more valuable to know what happens to the blood pressure after they've taken their morning medications. And so oftentimes I'll have a patient tell me, well, I woke up, I checked my blood pressure was really high, and I took my medications, and I'm like, okay, well then what happened? And so for me, I find it more useful to have a blood pressure reading at least a few hours after they've taken their morning medications, because I want to know, is the medication working? And so that's generally what I tell them. I tell them to, oftentimes in the beginning, I have them check it on both arms. At least that's what we do here in the office. I'll have them do that at home. I ask them to be in a kind of relaxed, calm environment at home, sit down calmly in your chair for at least a couple of minutes. And unlike us, most of the patients are using electronic cuffs at home. And typically the electronic cuffs, in my experience, is you have to check the reading maybe twice. And some of the newer ones will even average 3 readings for you. So I'll say, check it, wait 2 minutes and check it again. And in my experience, the second number tends to be the most reliable.
Yeah, I totally agree. We have the luxury in the office of not doing manual blood pressure cuffs. So I do feel like we do have that benefit, but yeah, averaging blood pressures I think is the best thing to do. I also try to have them do it a couple hours after their morning medications, not right before it. Sometimes, depending on the patients that are a little bit more compliant, I'll ask them to actually do maybe 1 or 2 throughout the course of the day, just because blood pressure does fluctuate. So I do want to see, not just what it is one time, but are they having other highs or other lows that may influence what we do with our medications?
Yeah, I think that circadian variation is a good point, because you do have some patients that their blood pressure will be borderline at other times of the day. And those, the patient that's not on medication, I generally like to have them do it first thing in the morning. I tell them to get up before they've had coffee, before they've done anything, sit at their kitchen table for at least 10 minutes, and then take their blood pressure 2 or 3 times and get an average of it. When you see the initial person, so that patient that comes in and they're, we don't often get the patient that's referred with a blood pressure of 145/70. I mean, typically those patients are on drugs. They're referred for some other reason, but occasionally we'll get that patient that shows up in the ED with a blood pressure of 190/100. So the question is really, does the stage of blood pressure when they present help you to decide on what you're going to do, how quickly you're going to get them on meds?
In my practice over the few years now, I kind of look at trends more than anything, because you'll always have these pinpoint episodes where the blood pressure may spike, which then causes an ER assessment, but you never know what was going on at the time, right? And so for me, I really look at trends, and I am a big proponent of home blood pressure, ambulatory blood pressure monitoring. Bringing in the log to me in the office of you checking is so paramount. And because I want to see it, they'll check it over the course of maybe multiple times during the day, and they'll document it, and we can actually look at the trends together. And so for me, I've found that having a log, having a trend of blood pressures is much more important. Even if for these patients who present with hypertensive urgency in the ER, oftentimes they may start a medication, but before I add a second one or up titrate the dose of the first one, I want to see what's going on over the next week or 2.
I think blood pressure logs are pretty essential for all of that, so you can see those trends. In my practice, if they have, and we'll get into the different stages, but if they do have stage 1 hypertension, I am more willing to give them, lifestyle modifications as the different guidelines recommend. So I will give them an opportunity to go several months of trying to see if they can decrease their stress, try diet, try exercise, weight loss as well. To try and help with their blood pressure before trying them on medication. So
prevention is huge, and lifestyle modification, like you just suggested, is paramount.
Yeah.
And I'm okay, if their blood pressure is in that, stage 1-2 range, it's okay to give them a trial of medical, not conservative medical, non-pharmacological treatment. Well, did you gain 10, 20 pounds in the last, 3 months? Can you try to get that back down? Because that's the difference of you having to take a medication or not.
Yeah.
Right? Are we addressing your sleep apnea? Have you gotten that treated? So there's a few things that I really like to focus on, when they're in that kind of borderline range where, if they just make a few changes and you give them 3 months and you watch them closely, you can avoid having to add a medication. Certainly we see the patients, like you suggested, the patient who comes to the ER and their blood pressure is 190, they're probably going to need something, right? But many of these people who come to us, you still have that zone where you can really not have to give them medication.
Yeah, I mean, I think that's a great point, and I think it does a lot to really, especially when we're first seeing the patient, to kind of strengthen that relationship that our decision is not take 5 minutes, take this drug, I'll see you in 3 months. It really is, okay, these are the things we've seen from your history, whether it's, you've got chronic back pain and you need to get your steroid injection, or, this is the stress at work, or you've gained weight, or you stopped exercising. All of those lifestyle things can have a huge impact. And I like to tell patients, especially when it comes to weight loss and sleep apnea treatment, look, you can avoid meds. And it's such a huge thing for patients, for motivating them to say, look, we can start with this and we may not have to put you on meds. And we got time. If you're in stage 1 and stage 2, we don't have to have you perfect. We've got a few months to get you there.
Seeing these patients who may be middle-aged, and I'm saying we're trying to protect the 65, 70-year-old patient of yours. Like, right now, you may be in that 40 to 50, mid 50 range, where if you make these interventions now, you'll be thanking, yourself and us later. So it's all about the long game. And I think that patients appreciate that, right? Because the last thing they want to do is just, well, here's a script for this medication. Yeah. We'll see you in 6 months.
I'm going to go through some definitions because we've kind of talked about stage 1, stage 2 hypertension. These are kind of from the 2017 ACC/AHA guidelines, and then really the types of hypertension. So really we're talking about, stage 2 being 140 or higher systolic, a 90 or higher diastolic. Stage 1 being in that, less than 140 but over 130. One of the things that I look at when we talked about the other patients and organ things is diabetes and chronic kidney disease in the stage 1. I think it's super important that we're really a bit more aggressive on those patients. Types of hypertension, I kind of break it into, they have all the other types, but to me, really the top 3 and the bottom one are the most important. It's like, do they have just essential hypertension? Is there secondary hypertension, or are they resistant or refractory? Because I think that drives our treatment algorithm and how aggressive we treat them. With treating hypertension, these are just several studies that have looked at patients' adherence to meds and whether they're totally non-adherent, which is sort of the PC way of saying they just don't take their meds, to they only take them sometimes. And it's really kind of staggering that it varies anywhere between 35 and 80% of people will have that are adherent. So up to 65% of people, patients we're treating, are just not adherent to the meds we give. Yeah. What do you think is driving that?
I definitely think it's the number of medications. There are a number of studies, whether it's antihypertensive medications or just medications in general. The more pills you add, the less likely they are to take medication. So if there are ways to do combination pills for antihypertensives or combination pills for other treatment modalities, anything that will decrease the number of pills that they have to take or the number of times that they have to take it. So I personally, in my practice, if I can try and put them on a once-a-day medication instead of a twice-a-day or even 3 times a day medication, something that will help with adherence, then I'll definitely try that.
Biggest pushback I see is when somebody has to take a medication multiple times a day. It's just hard, right? It's hard with you're working, you have different things going on, you just forget. So I think once a day dosing is really paramount. But then also, our patients will come to us and they'll have a long list of medications, and they may not even know entirely why they're taking certain medications. And so you have to take the extra couple of minutes to really explain to them, well, this medication is for this particular reason. Mm-hmm. It may not be a blood pressure medicine. This may be for something else. This may be for kidney protection and diabetes. So there's just some explanation that's involved. And of course, sometimes providers don't take those extra few minutes to do that. But it's the difference between your patient being adherent and not adherent.
Yeah. The flip side on that, though, is the patient who is anxious about their blood pressure, and you decide to start meds. They start on a once-a-day med, and they call 2 days later, and their blood pressure is not lower.
Well, we're starting you on this medication, it's generally going to take 1 to 2 weeks for us to see what's going to happen. There might be variations, as we start the medication and titrate the dose. But that's the key point, is that you will need dose titration, and you have to give time in between those dose titrations for the medication to actually work. Yeah. And so we talked about earlier about having trends. That takes time. And so I always preface these conversations to avoid that phone call, the next day about why is my blood pressure not coming down? Well, you got to give the medicine time to work.
And definitely, if you know that you have a patient that is more anxious, then you kind of get that sense ahead of time. I'll actually schedule those people for a little bit of a sooner follow-up to recheck their blood pressure, just to reassure them that, again, like if we start to see a little bit of a dip in their trends, that we're heading in the right direction, just give the medication some more time.
On that note, do you guys find much utility in some of these ambulatory home blood pressure readings? I know that's something that is sometimes popular. Have you guys found that to be useful when you're either starting a patient on medication or adjusting doses?
The biggest issue I've seen with ordering them is getting them approved and getting the patient to do them. I think I found more use in the remote monitoring that a lot of primary cares and clinics are doing, which I think is way more helpful as far as the patient's compliance with their reading, and then taking the factor of the patient bringing you the login out of the equation. So I honestly think that is really helpful, and especially if they're getting feedback on their readings, that your pressures come down over the next week, your trend is there, and it kind of takes the patient's anxiety out of the equation, because they just do it and it gets sent.
Yeah.
Yeah, and I think giving them a goal, and I think that's important to say, look, our goal is to get you your blood pressure to this number, but it may be over 3 months, it may be over 6 months. And the patient will always ask me, well, why do I have to take 2 medicines? And it's not any problem with the patient, it's the limitation of the medicines, how effective they are at lowering blood pressure.
If you try to maximize one medication by itself before adding on a second one, you're just subjecting them to more risk of side effects more than anything. So I try to preface with that as well, that, yes, I understand we can maximize the one medication, but I don't want to subject you to the risks of side effects of that, because there are dose-dependent side effects with some of the medications that are out there. So
Yeah, absolutely.
Some of our patients just want to hear that there's hope that they may be able to come off the medication in the future too. And I tell people that too, right? Like we talked about the reversible factors. Well, I'll tell them, well, hey, listen, you told me in the beginning of the visit you gained 20 pounds this summer. And yes, in the short term, we need to maybe treat your blood pressure. But if you can get that weight down, there's a good chance I'll take you off the medication. Yeah. Right? How many patients have you guys seen where they come and they may be on blood pressure medicines for 5 to 10 years and there's been no dosage adjustment, no medication adjustment, and the patients are now like, well, I don't even know, do I still need the medication?
Yeah.
Right. And so
you get that. I've been on lisinopril for 20 years. I don't even know if it's working.
Yeah, exactly.
So
but just giving the patient a little bit of a hope that, this isn't just you're going to be on this forever.
Yeah.
Part of the follow-up is not just the blood pressure, but how's your weight?
Yeah.
Did you get, your treatment, your sleep apnea test done? How's your salt in your diet? Like hitting that each visit, I think is helpful. We actually talked a bit about promoting compliance with treatment. I think we hit that pretty well. We talked about once a day medications and using ambulatory blood pressure monitors. But is there particular drugs that are recommended or that you see are most helpful to choose for both compliance and side effects?
I try to go based off of the guidelines, and the guidelines recommend, thiazide-like diuretics. My personal preference is for chlorthalidone if we can, keeping in mind that, somebody who's a little bit older, they don't want to have to use the bathroom a little, more than they need to. But chlorthalidone does have a longer half-life than hydrochlorothiazide. So that's my preference. It's a stronger medication. Then calcium channel blockers, the long-acting, nifedipine and amlodipine. And then the guidelines also recommend, either ACE or ARBs. And those are the 3 first lines. So that's what I try to do. And again, as we mentioned earlier, I try to do the once-a-day dosing. And then if we do have to do 2 different medications, try to do combination pills of 2 medications to, again, promote compliance.
Yeah, I totally agree with that. That's my approach as well. Sometimes I'll start with the, my ACEs and ARBs, although, unfortunately, after you see several cases of dry cough, sometimes you get a little bit hesitant, especially in certain patient populations for the ACE inhibitors. But I really like ARBs as my first line. Like you suggested, many of them are once a day dosing. There's room to titrate, minimal side effects. So I like those a lot. Calcium channel blockers are great. So that's usually my approach. And I often start low and slow in the beginning, even though you may see the patient, we'll eventually need 2 drugs, but oftentimes we'll start low and slow, and we can always titrate up.
The ARBs really across the population are probably the best tolerated. Do you see any difference in the ARBs? I mean, all of them, I think, but one are generic. So, and I don't use ACE inhibitors because, I used to use a lot of them only because of cost, but now cost is kind of a moot point because they're all generic. Do you see a difference between losartan, which seems to be the most common one, and the others?
Yeah, not a huge one. I oftentimes will start with losartan, and some of our patients may not tolerate the medicine, and this is very patient specific. I'm a big fan of valsartan as well, although oftentimes that's a BID dosing or twice daily dosing, but I find that's been effective for me as well. But usually those are my 2 go-tos, I would say.
I will prefer valsartan if I know a patient has heart failure and I want to get them on Entresto. So I will, go to valsartan in that situation and see how they tolerate the medication. This is valsartan Entresto, but yeah. I mean, to be frankly honest, it's probably not that much of a difference, but at least from a compliance standpoint, it gets them in the mindset of, BID dosing as Entresto is BID dosing. So
one of the things that I found like years ago, especially is when I was treating refractory hypertension, and I think, back probably close to 10 years ago when we were first talking about renal denervation, they were talking about a thiazide diuretic being incorporated, and there was a lot of discussion about which one. And I found way back then just better blood pressure control, but and what I've seen is a higher incidence of hypokalemia compared to thiazide, which I don't know if you guys have seen that.
That's my biggest kind of fear when I use these diuretics, even though they're very effective for what they do, is that time and time again, I've come into issues where the patient becomes not only hypokalemic, but hyponatremic, to the point where they're now in the hospital, and I'm seeing issues, and it's always right after I've started the diuretic. So I think there's definitely a role for it, but I preface I tell the patient, you're going to need to come in to get labs pretty regularly, and after we start the medicine, I'll usually check a basic metabolic profile in 7 to 10 days to watch the electrolytes.
I'll try to actually go to the long-acting calcium channel blockers first, just because they're very well tolerated. They don't affect your kidneys or anything like that. Because as much as we like ARBs, they do still can cause hyperkalemia as well as acute kidney injury. Kidney injury, same thing with the thiazide diuretics. So if I use chlorthalidone, it is in those patients that are more resistant hypertension, or something that if a patient, and again, this doesn't happen that frequently, but if a patient is coming to me for the first time on 0 medications and they are, 180s, 190s, in that situation, to be more aggressive to try and get their blood pressure down fairly quickly, that's when I'll go to chlorthalidone, but definitely check blood work in a week, just to make sure that there isn't any of those issues with their electrolytes or with their any renal function.
What's your guys' practice been for the patient who does, let's say, come into the office and their blood pressure is 180? Are you, in your experience, anecdotally, do you prefer to do upfront 2 drugs or, mid to high dose of 1 drug, right? Like a losartan 50 to 100 versus maybe a lower dose of losartan plus a second agent, whether it be a calcium channel blocker or diuretic. Have you guys anecdotally seen any kind of variation there?
Yeah, I mean, I generally go with the moderate to higher dose single drug, only because it's sort of a psychological thing with the patient with starting them on 2 drugs. Or occasionally I'll go to a fixed combo. So I'll go to a chlorthalidone ARB combo, or ARB HTTZ combo. So it's one pill with a combo.
I think it also depends on the patient, because if they are on 0 medications and now you're all of a sudden introducing 2 medications, a lot of them become reluctant and skeptical. And so in that situation, then I think we'll go to a moderate or higher dose of a single medication. Again, it's just knowing your patient and listening to what they have to say.
And I think the other thing is coming back to reiterating to them that, look, this isn't a solution in 1 week. Like, our goal is to get your blood pressure down over this 3-month period or 6-month period, and that, they want to take the one pill and it be normal, and really kind of reiterating that it's high. I know it's high. We want to bring it down. You're not in danger tomorrow. That leads into kind of the next thing. So how do you deal with the patient who checks it 9 times a day and checks it 20 minutes after each dose and then wants to take another dose because it's still high?
I try to educate them as much as possible that, yes, information is helpful, but there's also too much information. Because again, there are cyclical trends in their blood pressure, right? And if you'll see sometimes patients checking 24 times in a day and checking it 20 minutes, like several times. And in those situations, I try to explain to the patients, they're going to get more anxious every single time they see the next number. So I really try to educate them that, yes, they're trying to be helpful for themselves and an advocate for themselves, but it probably isn't, great for their own mental psyche at that point.
Sometimes it's as easy as explaining the half-life of a medication. When you give some of these patients who are very meticulous like that, oftentimes they are very data-driven and they're very objective. And when you give them specific information about the half-life of the medication, the onset of the medication, the bioavailability, some of them actually like that data. And all it takes is like, okay, well, that makes a lot more sense. And now maybe I don't need to check it 5 minutes after I've taken the medication.
These are the AHA guidelines as far as the follow-up that's recommended. And this is, again, I think this is helpful for telling the patients like where their goal is. Blood pressure that's just elevated, but not stage 1, just a recheck in 3 to 6 months. Stage 1 hypertension is really a monthly meeting until they get near their goal, and then 3 to 6 months after that. And same thing with stage 2.
Yeah, I think I agree with this for the most part, and what I try to do in practice. The caveat being, again, those patients that are a little bit more nervous, and I will check maybe have them come back initially within the first 2 weeks just to see how they're feeling and how the medication is going for them, especially if they've never been on medication before and they're anxious. Make sure they're not having side effects. But once they're comfortable and everything along those lines, then I'll again go back to spacing things out for the recommendations.
Yes, and I think that we talked about those reversible factors that we would want to try to address. That takes time, right? Weight loss, sleep apnea treatment, reducing caffeine intake, alcohol consumption. All of those reversible factors will take someone 3 to 6 months to work on, and so oftentimes, when they're in that stage 1 borderline zone, I will ask them to work on that and then come back in 3 months. To Varun's point, I will say, give me a call for a quick update, maybe in 2 to 4 weeks. You don't necessarily need to be seen in office, but you can send me a portal message, call the office, give me a few readings just to give me an update on how things are going. So I think in that stage 1, that 3 to 6 month, window for a follow-up is very reasonable.
Especially when initiating therapy, if I'm setting them for a basic metabolic panel for their labs, having it done before they come in so you can review it with them, make sure they're good and adjust. I think all that makes sense. So let's talk a little bit about race and gender. So we really all know that African American population have much higher rates of hypertension and much more difficult to control, as well as the Hispanic population. And the data really is, if it's 50% of all Americans have hypertension, it's higher in the non-Hispanic Black population, and even 40% of women have hypertension. So there's, again, I think it's an old thing that, hypertension was the purview of men and purview because of their stress and their diet and all the risk factors we talked about. But I think there's definitely populations that are undertreated. I guess the question is there anything different in the treatment that you think works better in different populations based on race or gender?
Yeah, I would say that in my particular practice, I typically will avoid ACE inhibitors in the African American population just because I feel like the incidence of angioedema is significantly higher in that group. And so I typically will avoid ACE inhibitors. On the flip side, I find that, hydrochlorothiazide, chlorothalidone, these diuretics typically tend to be more effective. And so I'm a little bit more lenient. I mentioned the electrolyte disturbance issue is a concern, but oftentimes I find that in this population, the diuretics work really well.
There is evidence that shows that the African American population, they do have higher rates of angioedema with ACE inhibitors. So I too also try to avoid that. And then I'll actually try to use calcium channel blockers a little bit more in this population.
Yeah, I agree. I think I go to calcium channel blockers earlier. I still do use some ARBs, but I think the diuretics and calcium blockers are probably a better first line treatment. We kind of talked about our initial drug for treatment. Now let's talk a little bit about the special population. So those patients that have underlying disease, that have, say, stage 3A chronic kidney disease, or they have atrial fib, or they have diastolic heart failure, or even systolic heart failure. Does that change your initial drugs?
If it's for chronic kidney disease, for example, as long as there's no absolute contraindication to it, I think, and they have, things like microalbuminuria, I'll definitely go towards ACE or ARBs, preferably the ARBs, as we discussed for various reasons. But the ARBs are what I try to use there. For heart failure, if they truly have hypertension with heart failure, I will aim towards the beta blockers that have more of a antihypertensive component. So like carvedilol, for example, just because the alpha blocking effect. So I do think that the different disease states, I do try to tailor a little bit more. So if I can do a combination of impacting different, illnesses that they may have.
Yeah, I totally agree. So, especially in the heart failure population, which we obviously see a lot of, the afterload reduction is really critical for those patients. And for them, I'm very aggressive about the ACEs and ARBs up front to get that afterload down, right? And so really it's that's my focus there versus, a patient who may be fluid overloaded. A diuretic may be more effective for them in terms of, pulmonary edema. That's late stage, obviously, but in the office, you may see them with lower extremity swelling. So a disease state definitely matters for these patients.
Yeah, and then what I will say is that, with chronic kidney disease, sometimes our first-line agents don't work as well. And so that's where you can reach towards the loop diuretics are actually a little bit more beneficial for blood pressure at that point. So that's when, if I know that there's CKD stage 4, as long as I'm just having a discussion with their nephrologist as well, that's when you use those loop diuretics additionally.
Yeah, I think as their kidney disease becomes worse, I think their volume overload and their salt sensitivities, and I think the loop diuretics definitely are worse. And I think the patients that have hypertension, have their first onset of atrial fib, I think going to one of the beta blockers is typically my. Do you think there's a difference? You pointed out using carvedilol. Any difference between that, metoprolol, atenolol, nebivolol? Do you guys have preferences?
Yeah, I think it depends on the underlying issue. If we're talking about systolic heart failure, there's only 3 medications that we really use. So out of those 3, that's where I tend to use carvedilol just for the blood pressure, because it is a better blood pressure medication than metoprolol by itself. If they truly have no heart failure, and I do need to use a beta blocker, that's sometimes where I'll go to labetalol, just because that is also one of our medications that we use for hypertensive emergency. And I do think that that's probably, at least anecdotally and in my opinion, a little bit of a better blood pressure medication from a beta blocker standpoint.
Yeah, I totally agree. When the patients, come to me for 2 issues where they're, maybe have AFib that's poorly controlled and their blood pressure is really high, like Varun pointed out, I think the alpha effect of the carvedilol has been very effective at both lowering the heart rate and the blood pressure. Whereas if I just need to control the heart rate and maybe the blood pressure is already maybe borderline, metoprolol is often, a better choice there. Nebivolol or Bystolic is another one that I reach for often when I need that extra, systemic hypertension effect in addition to rate control. You get the 2 for there.
Yeah.
So I really like those 2 drugs for that.
Yeah.
Yeah, and I think I've leaned a little bit more to the nebivolol in the younger population when I have them on something else, and if I have them on an ARB at a tolerable dose, a dose of thiazide diuretic, and sometimes I'll go to that instead of a calcium blocker, especially if some of them have had edema with amlodipine. I find the younger population, I think, tolerates it, but the side effects of the beta blockers a little better.
I agree.
With
And with carvedilol, oftentimes, we talked about this earlier, but oftentimes that needs to be used in a twice daily BID regimen, whereas nebivolol can oftentimes work well in the once daily regimen. So when we're talking about adherence, there's some things you have to consider there too.
So is there a medication class do you think that we're underusing, we should be using more of?
Sodium receptors and we talked about spironolactones and the so-called MRAs, aldosterone receptor antagonists. I find that those are going to be very helpful for me for refractory hypertension when I'm reaching for a third medication. That has been very effective. You get the kind of indirect diuretic effect, but also because of the effect on the sodium receptors, you get some nice blood pressure lowering effect, and it works good as an adjunct to your ACE-ARB or to your calcium channel blocker.
Yeah.
Keep in mind that you have to be cautious when the patients have chronic kidney disease or any sort of potassium issue, because oftentimes these medications will cause hyperkalemia. But when the kidney's okay and the electrolytes okay, I really like spironolactone as a third line agent.
Yeah. Sometimes in that same situation, I'll also look at clarinone, because it has the less of the androgenic effects. The only caveat to that is, again, it is usually better tolerated as a twice-a-day medication. So that's another thing if we're talking about patient compliance. But again, this is more so for that resistant hypertension. I actually don't really recommend clonidine. We do see that quite a bit, where people will use that even as a PRN to try and help bring down the blood pressure even temporarily. But the problem with clonidine is there's so many different side effects, from a neuro aspect, but also it can cause rebound hypertension. So frequently what I'll see is I'll see patients who get put on clonidine as a PRN for hypertension, then they take it, and then their blood pressure comes down, and then as the medication wears off, then it comes back up again, and then slowly it's gone from a PRN to they feel like they're taking it all the time to try and help with that. And so it takes some counseling at that point to try and get them off of it and wean them off of it, just because of all the alpha effects that it can have. So I try to avoid, or even if I see patients on clonidine, immediately try to take them off of it. That's my biggest pet peeve overall, even in the hospital setting.
To that effect, I also see a lot of patients get put on like doxazosin or terazosin, and it's one thing if you're treating maybe BPH and you want to get a twofer, treat the prostate, get the blood pressure down, but sometimes I'll see no prostate issues and they're getting put on these medications, and in my experience, the orthostatic hypotension and the orthostasis I'm seeing from these medications far outweighs any benefit, so I generally rarely will use those.
Are there any meds that you find that are used a lot that are not really helpful, or that you think we're seeing more of but aren't as beneficial for patients?
I've seen patients who've been put on these medications and then they're on Eliquis for AFib, and then they've had syncopal events, and then they've hit their head, and then all of a sudden, we're talking the whole,
And again, I think I agree with you totally. I think, and especially the elderly population, where they tend to have greater swings in their blood pressure, more likely to be orthostatic, which unfortunately is the population in men that are treated for prostate. So I think it limits a bit what we can do with that class of meds. We've kind of nicely moved into talking a bit about the drugs for refractory hypertension. So if you have that patient you've now been treating for 3 to 6 months, their blood pressure is still high. What are the key points that in the history or physical that make you think about secondary hypertension?
Do they have risk factors for sleep apnea? I think that's something that it's quite easy to elicit just from history as well as physical exam. You can, look at the stop-bang score and things like that to try and elicit that. Also their age, if they're younger, and you don't, from a history, you can't think of any or find any other secondary risk factors. That's when I start to try and investigate even further, to try and see whether or not they have some sort of, do they have hyperaldosteronism or anything like that, FMD, things like that.
I see a patient have big swings in blood pressure, where you have sudden onset of really severe high blood pressure, and then maybe the next day it's back to normal, major swings, I'm more likely to look at things like hyperaldosteronism or, sorts of adrenal adenomas or some sort of, pheochromocytomas. If I see big swings like that, renal artery stenosis is something that we're going to be talking about shortly as well, but that's one that I'll look for. But for those big swings.
The other thing that I would put in there is when the onset of hypertension to me over the years has been, typically hypertension clusters. So usually before age 40, over age 60. So I found the patients of FMD that I found have almost exclusively been women between 40 and 60. So again, for me, that's a history point that if I have somebody female hypertension onset in that age group, I definitely look for it because that's the population I found it in. What do you order? Do you order like just a battery? Let's order everything. Do you try to do it selectively? How do you guys approach if you're worried about secondary hypertension?
Again, kind of depending upon their age. If they're young, I'll pretty much look at almost everything, just because, again, hypertension at a young age, especially if it's uncontrolled, will lead, they have their entire life ahead of them. So I want to make sure that we don't have anything that can be causing anything like Cushing's or whatnot. So I'll try to be as aggressive as possible early on if they're in their 20s, early 30s. That's kind of my biggest.
Yes. So the benefit from finding it is great because they're going to have hypertension for a long period of time.
Yeah, I'll routinely, if I'm, highly suspicious for a secondary cause, whether it be a pheo or some sort of adrenal adenoma, serum urine metanephrines, cortisol level, baseline cortisol level, aldosterone levels, that's kind of my lab workup. And then imaging workup, I'll, renal ultrasound, CT abdomen pelvis, and oftentimes this will be in conjunction with maybe an endocrinologist, working with them. So as I'm referring them to look for these other causes, I'm starting the workup.
Yeah, got it. And I do screen almost every single patient whether they're young or not, I'll screen almost every single patient for sleep apnea. Because sometimes, it's somebody who you don't suspect may have it that will end up having it. So
got it. Yeah. I mean, I think we tend to think about only obstructive sleep apnea, but the central sleep apnea patients we miss them if we don't look for them. The other thing I find helpful for, especially looking for renal artery stenosis, is do they have PAD? Mm-hmm. And so a patient who has PAD, hypertension that's refractory, I think the positive predictive value for looking for renal arteries is high. Yeah. And I found renal artery ultrasound to be pretty helpful. I mean, I know there's people who use MRA and stuff. I haven't been as thrilled with the MRA imaging, how well it correlates with invasive angiography. Mm-hmm. But renal Doppler, at least in my mind, pretty good at giving you it's less than 60, over 60. Is it worth going the next step? Mm-hmm. At least that's the way I use it. I don't know.
Yeah, I totally agree. So I think that renal ultrasounds have been great. And I definitely incorporate that into our practice, especially if there's resistant hypertension. Like you said, PAD, but if they also have a smoking risk factor, or if I see plaque on a CT scan for other reasons that we may do, then I'm more likely to try and screen them for renal artery stenosis.
Yeah, I think that's kind of a good point. It kind of brings up, we have those patients that are smokers that they get now a screening ultrasound at the Medicare age for AAA, right? Mm-hmm. And then they don't have a AAA, but they have plaque. Yeah. And so it's kind of one of those things where, okay, they already have evidence of atherosclerosis, so they're going to be a higher likelihood. Yeah. So that's a great point. We kind of talked about secondary hypertension. Now, really what we want to talk about is renal denervation. And this is really the exciting thing is that has now been just recently available and approved, that really has been a long time in coming. I mean, I can remember going to TCT nearly 10 years ago for the initial trials with renal denervation with different systems, everybody being real excited about it and the trials kind of flopping. Mm-hmm. And so it seems like there's been this long time to really try to figure out how to do the procedure well and to really see does it make a difference. Do you guys want to comment on how does it work? What's the basics for renal denervation?
The way that this essentially works is we're using a catheter that goes directly into the renal arteries. And what we're using is that these special catheters have different types of electrodes on them. And they are able to burn the sympathetic nerves that go to your kidneys. And that sympathetic tone, by burning those nerves, essentially you end up decreasing renin levels overall, because your sympathetic system is correlated with renin release, and then by decreasing the renin and therefore the RAS system, you end up decreasing vasoconstriction and all of that stuff, and angiotensin II and whatnot, and it can control blood pressure from that aspect. So that's why it can be a pretty helpful tool that we have nowadays.
So it's kind of treating, for lack of a better term, what ACE inhibitors and ARBs done a little bit further up the system.
Correct, yeah.
Benefit of the particular new platform that we're using now is, like Bruin pointed out, this one catheter, which happens to be pretty atraumatic and doesn't leave anything behind. We're not leaving a stent behind, but there's multiple electrodes to treat the largest segment of the renal artery. And I think that has been very effective, at least in the trial data. We've seen significant benefit.
I just want to play this little video. Just in my mind, I tend to be a super visual thinker. And so seeing this, if you guys just want to comment, so just to set it up, these are sort of schematically what the sympathetic nerves look like around the renal arteries. And typically there's multiple branches. Is there a difference in the density of the nerves related to the position in the renal artery?
Yeah, so based off of the different trials and whatnot, it appears as though that a lot of the sympathetic nerves are actually a little bit, as you can see, where the renal artery actually branches. And so that's why when we do these procedures, we try to get a little bit deeper into the renal artery and more distal than the more proximal aspect of it. And then thankfully, these electrodes on this specific catheter, there's ways for you to turn on and off specific electrodes in order to get to the location that you want to.
And the other benefit you saw there in that demonstration was, when you pull back the stylet or the guide wire that you have in the catheter turns into a spiral, hence the name spiral, which creates maximum contact of those electrodes with the renal artery, allowing you to deliver the therapy in the maximal surface area possible. And again, this is typically done through a femoral artery access point is kind of the standard. With a sheath, you have a catheter up. You typically want to do a renal angiogram with your choice of diagnostic catheter first to define the anatomy, after which you want to put a guide wire up and then deliver the catheter. So these are just some technical aspects of the procedure, but the nice thing is, again, you're not leaving anything behind.
And then on top of that, when we are doing these procedures, we do end up trying to get into every one of these branches that you can see. So when it does trifurcate over there, as you can see, we would try and get into each one of those in order to maximize the amount of essentially ablation to those sympathetic nerves as possible.
Yeah, and I think that's part of the learning for this technology has been sort of the thought was the bigger the artery, the more the nerve plexus is, and it actually turns out that it's really in those primary branches and sometimes the secondary branches, and I think that's what's made a difference in the improvement in the technology and in the ablation. Yeah, the fact that it's atraumatic, there's nothing left, that the treatments and the system has the ability to tailor each one of those 4 electrodes to turn them on and off and treat specifically what the anatomy shows you, I think is helpful. Big concern when I first heard about renal denervation, having done renal stents since the early 2000s, was it's going to damage the artery. And so what was helpful for me was really looking at some of the safety data to really show that any injury to the renal artery is incredibly low. In the trials, there wasn't really any significant difference in renal function or the actual renal artery by angiogram or by CT after the procedure.
Yeah, there's minimal things that are long-term, including like fibrosis or scarring of the artery that you would think would also result in a renal artery stenosis from that aspect. We don't see that either, at least in the current outcomes that we have available to us.
Big thing that obviously led to the approval of the technology was the clinical trials. And so there's really 3 big trials that showed the efficacy of the procedure. And unlike the renal denervation trials that were done 10 years ago, those initial trials were only done in patients on meds. In order to be enrolled, you had to have 3 meds, including a thiazide diuretic, to even be enrolled in the trial. And the results were very mixed. So the most recent trials have really looked at people off meds, saying that person that hasn't been treated, those that are on meds, to see if there's a difference. And then there's a global registry to really look at a larger population. So to me, the interesting thing was, we talked initially about that, 10 millimeter of mercury reduction showing a significant cardiovascular effect. The fact that the trials have shown, literally 10 millimeters or more was, to me, was a great thing supporting the use of the therapy.
Whenever we consider any invasive treatment, we're always weighing the pros and the cons of the treatment, right? And in the past, that calculus may have been different because of trauma to the artery or procedural complications. Now, with the design being atraumatic, not leaving anything behind, I think that this is generally a very safe procedure. And so when we're weighing the pros and cons, we're more likely to turn to an invasive approach because we can get the benefit we want without necessarily putting our patients at risk.
Additional benefit is by reducing the blood pressure by 10 millimeters of mercury. That can also get patients off medications. Right, and then as we discussed earlier about patient compliance and number of medications, if we can get people off the medications, they are more likely to be compliant and therefore get that additional benefit from those medications where they might not have been if they were on that lower end of compliance of 35%, I believe the number was. So that's an additional added benefit as well.
Studies showed that the higher the blood pressure was going in, the better the benefit, which was kind of interesting, which would really basically say it is driven by that sympathetic tone and driven by that increase in renin. This is an early technology, but when you ask the patients about it, we're treating an asymptomatic state in your blood pressure. Would you be willing to go through an invasive? And it was surprising that patients were definitely willing to do it and were much more likely to say, yeah, if I can do it and not have to take an additional blood pressure medicine and get my blood pressure down. There wasn't a lot of reluctance to go through it.
As we're seeing younger patients who come to our office now, and in the era of the internet and this access to information, patients are just more hesitant to take medications, period. And so when there is therapy that's offered that's generally safe and the benefits of the procedure potentially outweigh the risks.
There's definitely patients who want procedures just to avoid being on medications and potential side effects or long-term effects from those medications. So it makes total sense why people, especially younger patients, want to try and avoid, medications.
Yeah. So I think it's really, really encouraging. Obviously as interventionalists, we enjoy doing the procedures, and at the same time, I think we always have this heightened awareness for safety and wanting to say, look, we're really going to benefit the patient. But again, I'm excited that this technology appears to be very safe and appears to have a really good efficacy. The Society of Cardiovascular Angiography and Interventions came out with a statement with regard to renal denervation because it's relatively new. And I think, I really kind of agree with this. In patients with uncontrolled hypertension, where we've done lifestyle, we've done medications, we've gone through this, and we're at the point where their blood pressure is not controlled and they really don't want to go on another medicine. And they've really said, look, we've talked about this as an option. Those are great patients for this. And I think also the other patients that I see is those patients that have the underlying disease, have the chronic diastolic heart failure, have systolic heart failure, have other issues where if we can control their blood pressure, they'll benefit aside from blood pressure.
That pretty much sums it up really well. I think these patients who are now, on 3 drugs, still refractory, may now have side effects related to the medications. I think these patients are great candidates because, again, but like you suggested earlier, it's always about the pros and cons of the procedure, right? And the risk benefit of the procedure, especially when we're talking about invasive procedures. And I think, you're hard pressed for someone who may not be on any medications, but just doesn't want to take medicines to get a procedure versus the patient who is on 3 drugs and now max doses. I think that every patient is different. And so I think this is definitely a good start.
The thing is with a procedure like this, the effects you don't see the effects like months down the line. The effects of the decreased blood pressure are fairly, immediate within the first couple of days. So I think it's something that is important to keep in mind. What I will also say is that, again, as right now, this is for resistant hypertension. So it's not for those patients that are not on any medications, right? Because I don't know if you guys have seen this, but I've had some patients who've asked about, using this because they don't want to be on any medication whatsoever because they're not on any right now. But as of right now, that's not an indication.
I totally agree. I don't think this is for the 50-year-old who is overweight, has probable sleep apnea, follows a terrible diet, and blood pressure is elevated and doesn't want to take a medicine. I mean, I think this has got to be put in the context of lifestyle modification, and it really should be, we should be using it on those patients that are refractory and are going to get the most benefit.
Yeah, I do think that this is a nice added tool that we have other than just medications. But ultimately, I think the best first thing is lifestyle. There's a lot of literature that shows that things like, weight loss, 5% of your body weight, if you lose weight from that aspect, DASH diet, decrease sodium, all of that stuff is very beneficial to helping decrease your blood pressure. And each one, as an additive effect, can drop your blood pressure from 5 to 8 millimeters of mercury. So if you do all these things, exercise, the combined can be potentially enough to avoid being on medications, but it's just about the counseling.
Yeah, I agree, and I think that's put really together. And if we put it into lifestyle meds, and then now we have a third option, right? And so they should all be complementary. It shouldn't be jump over one to avoid the other. The big question is, if you have a patient who's going to go through the procedure, I think this, I think for me is real helpful, is kind of say, what can they expect? And if you look at, a quarter of the people are going to get greater than 20% reduction in their systolic pressure. And even 60% will have greater than 5. So it really is pretty effective across the board in that 10 to 20 range. We're talking about a large percentage of patients that will benefit from this. I like the way you put it, Varun, was like telling the patient, if you lose 5% of your body weight and you get your sleep apnea treated, your blood pressure will come down 15 points. And this is the reduction. Putting it in that same context with this procedure, I think is helpful.
Yeah, just giving patients goals, right? A lot of our patients want goals, and what are the realistic expectations of a procedure like this? I think is really helpful, because you really should set those before you go into the procedure.
You got any other comments about renal denervation we didn't hit on?
I think the experience is still early, and I'm excited. We've been, like you said, we've been talking about it for a really long time, and we've been waiting, and the initial data wasn't that impressive, but the most recent data is definitely convincing. And so, is it ready for prime time? I guess we're going to find out once we start doing cases and get ready to go. But I think the initial experience is very, very exciting.
Interested to see when they get to the point of where we can do this from a radial aspect. So, that's where I'm kind of looking forward to. Yes, we do this through groin approach right now, but radial is more minimally invasive, and patients are able to get up pretty quickly and less bleeding risk from that aspect. So that's going to be the thing to look forward to.
Yeah, to that point, the biggest complication from this procedure seems to be related to access. And so if we can convert the access, just like we've done in the coronary, to reduce that to a radial approach, that should be just another thing to say, look, the procedure is safer, and we may be able to offer it to a broader range of patients. So my common sense algorithm is really confirm the diagnosis, make sure we rule out white coat hypertension, checking their blood pressures at home, really, really stressing lifestyle modification, really at every visit. And we talk about medical therapy. What are those things that are going to make a difference? What's their underlying disease? We've then taken them through that titration. If we get to that where they're refractory, or we think they have secondary cause, getting that workup done, and then really targeting the renal denervation for that patient where we've gone through this, they're on 3 meds, or they're higher risk and their blood pressure is not under good control. I think that's the place for it at this point.
Not just skip from one bucket to the next, it's every bucket adds on the next, right? So you're going to keep still doing your dietary and your lifestyle modification, but we're going to try this, but this is all additive and it's all adjunctive. Because if you try to do one piece without the other, then it falls apart. And that's how you lead to poor patient outcomes, dissatisfaction with care, and then it's just, a bad outcome. When do you think that the referring providers should really start thinking about referral? Not necessarily just for renal denervation, but just in general for overall cardiovascular assessment in these patients.
Ideally, the patient who has hypertension, who they've gone down this path for the 3 months and their blood pressure is still not controlled on one, maybe two drugs, I think is a good time to refer. Or even at the initial evaluation, if their EKG is abnormal, suggesting
Absolutely.
left atrial enlargement, hypertrophy, or they have symptoms. So they've got peripheral edema, they're short of breath, they've got something else that's there suggesting underlying cardiovascular disease. I think early referral is better.
I think also if they have other risk factors or other comorbidities, I think that's kind of important as well, especially diabetes, smoking, things like that. Because again, could this be something else, like renal artery stenosis? Could this be in conjunction with like a heart failure diagnosis or whatnot? So I think that that's kind of important additionally.
That population of the heart failure with preserved ejection fraction, those patients who have the classic comorbidities, they're very short of breath, typically their left ventricular filling pressures are high. And those patients, if they're lucky, they'll have evidence of end organ damage, maybe on the EKG or the echo or whatever, just so we can get to them early. Maybe the symptom is just shortness of breath. And I think that patient population has been underserved for a long period of time, both by cardiologists as well. And we have good treatment options for them, including, Entresto and some of these, ARNIs, so-called. But that's a big population that we're missing, and we need to be more aggressive with them.
The echo is super important in that patient because getting that early diastology is super helpful and letting the patient know that there's already evidence of end organ. And that's so beneficial for their treatment.
Yeah,
I totally agree with
yeah, and especially because diastolic dysfunction is also spectrum. So if you catch it early enough, maybe you can prevent it from progressing to the point that they truly have elevated pressures within their heart. So being able to be aggressive, catch things early, again, it's about prevention.
Well, and now that we have better therapies with SGLT2 inhibitors, the other drugs, before those other therapies, it was pretty much hypertension treatment.
Yeah.
Now we've got other treatments, so I agree with that. I think that makes a lot of sense. Any final comments you guys have?
Oh, it's just really exciting. I mean, you think it's a topic that we've been discussing forever, but it's amazing how the new treatment modality is both non-invasive and invasive. So despite this being, a 50+ year, evolving treatment modality, things continue to change and even, we're constantly learning.
Yeah, I agree. So thank you both. I appreciate this conversation. This was great.
Thank you.
Thanks.